proposal of the pathophysiology of disease was the imbalance of the four humors in the body. This imbalance causes disease, and in order for you to restore that balance, you need to relieve one humor over the other. And then we had Aristotle, who proposed for the first time more than 2,000 millennia ago that the heart is a pump. How it functions, what it pumps, what's the circulation was ill understood at the time. It wasn't until this very eccentric surgeon, he was the surgeon for the Roman army in Rome, and he was the physician of the emperor who did a lot of public dissections. And he was the first to propose that the heart pumps blood. But his model was a bit skewed from our perspective nowadays, where he thought that the blood originated in the intestines and the liver, went through the heart, through the interventricular system, and then evaporated in the brain. Mind you, the idea of circulation or circulatory system was huge and revolutionary. Now, for 2,000 years, Galen's theories dominated medical practice worldwide. In fact, our famous poet, Al-Mutanabbi, he says, يَمُوتُ رَاعِ الضَّأْنِ فِي جَهْلِهِ مِيتَةَ جَالِنُوسَ فِي طِبِّهِ. So again, it took another step of revolutionary thinking. Ibn al-Nafis was the first ever in history to propose that there is a circulation. Now, he did not describe the systemic circulation, but he described the pulmonary circulation, or in Arabic, الدورة الدموية الصغرى, the minor circulation. And through his manuscripts and everything that he has written, it was later adopted that there is a systemic circulation. Now, nobody can speak about cardiac science or cardiology or innovation in medicine without alluding to this artist, pioneer, engineer, thinker, Leonardo da Vinci. And his distinct imprint on history and innovation came from the mere fact of his acute observation. He had this unbelievable interest in understanding things, how they function, how they work, and describing them. And here, for the first time in history, in reviewing his notes and his codes, that most of them don't survive, but these are some of the specimens that survive in Oxford, he describes the cardiac anatomy like no one before him. In fact, a lot of his illustrations verify some of our current understanding of the function of eddies, currents, sinuses of Valsalva, coronary anatomy, and valve function. Now, the way the circulatory system is described is attributed for the first time in history in the 1600s to William Harvey, who was the physician for the British monarch. And through the review of the notes of Ibn Nafis and through astute observation, he was able to describe the circulation. Now, all of this, you can see there is a huge progression through history. And as we progress in history, the intervals between each and every revolutionary step is more short and acute. But until earlier in the last century, it was thought that operating on the heart was impossible. Who would have thought that you can open a human heart, fix whatever is there to be fixed, and restore that circulation? So it was a taboo to operate on the human heart. In fact, Stephen Paget, who was a famous 19th century surgeon, clearly said, whoever operates on the human heart should lose the esteem of his peers, because operating on the human heart was lethal. Now, just 20 years later, and less than that, a medical student who saw the president of France getting stabbed, a lethal wound, and have a massive injury to the inferior vena cava, die in France despite the care of the best medical minds. And the reason was massive bleeding from a perforated vascular structure. And he thought then, why can't you sew and fix blood vessels like you sew clothes? Everybody laughed at him. Well, he went and did an internship with an embroideress, described his technique for vascular anastomosis, and guess what? He is currently thought of as the father of cardiovascular medicine. He went on to work with Charles Ginzburg, the famous person who flew solo across the Atlantic, to describe the earliest models of the heart-lung machine. In fact, they experimented with connecting dogs' heads together and keeping the circulation going. Now, add a few years later, people were still figuring out, how can I operate on the heart? Now, the heart is pumping. If you stop the heart, then you kill the patient, or you kill the specimen, or you kill the organism. So different modalities, and this was one of the earliest one for operating on children with ASDs, is putting them in a cool tub, cooling them down to less than 18 Celsius, waiting for the heart to fibrillate, and then opening the thoracotomy, doing a thoracotomy, fixing by direct suture the ASD, and rewarming the patient and shocking him or her. Again, it worked. And then Walton Lillyhike in the 1940s came with his cross circulation apparatus, where a blood compatible, usually a parent or a relative, was used to pump oxygenated blood and take back deoxygenated blood. And believe it or not, 43 patients benefited from this revolutionary technique at the time. Now, it wasn't until 1954, 1952, when Dr. John Gibbon, now it's very amazing how Dr. Gibbon came to pioneer his heart-lung machine. And this is the first prototype. So when he was appointed first at Mass General as a junior physician, he was given a small, dusty lab at the basement of the hospital. No budget, nothing. And was told to work on whatever project he was interested on. People at the time were interested in major surgeries, reconstructive surgeries, grafts, flaps, anastomoses, but he still had a dream of being able to stop and supplement the circulation, the systemic circulation, through a membranous or bubble oxygenator at the time. In fact, he hired a nurse part-time who he ended up marrying, and she became his wife. And through thousands, took him almost 15 years without budget, without funding, without recognition. In fact, his chairman was against him because he thought his idea was a waste of time. And unfortunately, many patients died during experimentation. But now we have the full credit to the heart-lung machine and to him personally for allowing us to be able to operate on human hearts. And again, the heart is an amazing organ. You cannot proceed and add new thinking to the way we operate on the human heart without admiring its beauty and how a miracle each beat. It's the source of life, and so it's the foundation of life and the source of all action. So I'm not going to go to the innovative things I've worked on over the last 10 years, but I've had the honor and pleasure in working with a team where we got 3 US patents for devices to be used in cardiac surgery, as well as described 3 new procedures. And there are a couple in the pipeline. But again, the process is not easy and straightforward. And this is the mantra I use when you think about innovation in cardiac surgery. In fact, if you think about innovation in anything, be it in medicine or otherwise, there must be a way to make it better. Now, you might say, well, we have good results. TAVI is great. Open heart surgery is becoming standard day to day. There must be a way to make it better. Not necessarily the whole procedure, but each and every step of the procedure. And the simpler, the better. So that mindset really will revolutionize. You really don't need to reinvent the atom or come with something new. But think of the things you do day to day, the things you have most experience in. And this is where the 10,000 hours, the high volume, the high repetition comes in. You cannot think of a problem or innovate without having spent thousands and thousands of endless hours thinking about that problem with keen observation. And then you will start to realize, how can I take things that we do routinely or that the routine problems we face in the operating room and make them easier and better? Also, a key function here is to work with the pioneers, with the innovators. I've had the pleasure of meeting a lot of the pioneers, and some of them I've worked with them closely. And I've gone through the way they think, the process, how they got to invent, innovate, and advance the field. This also really added a lot to my understanding about what innovation is and how to progress in cardiac surgery. One of the things I usually kept, now I don't do it as much, but from my early days in residency, is I kept copious notes about each and every procedure that I've attended with surgeons. Now, these notes might not seem much, But in retrospect, this is how you think. It's a process. When you train your mind to think in 3D, at the time, we were fortunate not to have cell phones or video cameras. Video cameras were big. They weren't allowed in the operating room. There were some privacy issues. But being able to photo-visually recognize an operation, memorize each and every step, think in 3D, jot it down on paper, challenge your mind how to put it down on paper, really helps you find solutions and things that otherwise would have not appeared so obvious. And again, this is how I use this to come up with solutions. I think of the day-to-day steps that we do in the operating room, each and every step. When I go back home and I have the time and the leisure of drawing things, then I can put it down on paper. And then you start to analyze. Now you start to think in a scientific way. Now, instead of the artistic way, now you go to the scientific way. This is a procedure I described a few years back, spiral aortoplasties for dilated aortas in high-risk patients, where it saves the patient the risk of having a graft replacement. It expedites the procedure, redistributes the tension. I found it very helpful in my 50 or so patients that I've operated on recently, and the follow-up was great. And again, you go back sometimes in the middle of the night trying to think, how can I make it better? I've already gotten patent, but no, there must be some other ways, some other uses to make things better. The prototype had some issues. You go back to the drawing board and try to come up with solutions. And sometimes you need to do bench experimentation, which we've done in some of our prototypes, where you actually, before testing on a patient, you would go in the lab, and in this case, it is our operating theater using standard operating room equipment, and test your hypotheses and collect data, collect measurements, and hopefully publish. And I've been fortunate to have published a few papers that really were based on pure theories and experimentation, and I've got the pleasure of seeing it implemented in practice, either by me personally or by some of my colleagues. So when it comes to innovation, everybody has ideas. Everybody, I'm sure if you walk down the street, everybody has ideas and proposals. But it's always the challenge to take the idea from just mere idea, a dream, a talk, and implementing it. Now that part is what gives agony. This is what causes sweat. This is where you need to be very, very patient, because we're talking about years and years. And what I've noticed in innovation, you'll meet some people and will say, oh, he has 20 patents or 30 patents. It's useless, because you can spend a lifetime just working on one patent to make it something useful, commercially available, and have an impact. And this is the hype of innovation, where you have initially there's enthusiasm for an innovation or new therapy, and then you come to the realization of the limitation of that innovation. You go through the bottom of disillusionment, and then there's the slope of enlightenment, and then the plateau where the actual practicality. Now, this scheme, this loop can take sometimes years and decades for the realization. I'd like to end this by just one of the things that really helped me in innovation, not only in innovation, in cardiac surgery in my personal life, what is called the 6 pillars of high performance or success. That is motivation, focus, confidence, energy. That's very crucial. I'll talk why. Purpose and leadership. I haven't had the pleasure of enjoying lifelong endurance competitions. I do triathlons and Ironmans. And one thing for you to success, one important factor for you to come to the finish line is for you to manage your energy. That is, if you want to do a lot of things, you have to start slow. And I'll finish by this quotation from Albert Einstein. The intuitive mind is a sacred gift, and the rational mind is a faithful servant. We have created a society that honors the servant and has forgotten the gift. Thank you.
Thank you very much, Dr. Khan. If you could join the panel, and we'll take the questions at the end. Our next speaker is Dr. Feras Khalil, who is a cardiac surgeon from King Faisal Specialist Hospital. a well-known surgeon and a surgeon who works a lot with robotics. And we will hear from him about mitral valve surgery, robotic mitral valve surgery. Dr. Feras, please.
Thank you. So, thank you very much for the invitation. Yeah, you want to remove the step? Yeah, thanks. It's a great honor. So thank you for inviting me here. Thank you for everyone staying here until this time of day. I put something very quick together. And it's going to be, so I'm talking about mitral valve, but I put extra stuff that we were the first center in the world to perform robotically. So bear with me. I'm going to go rather quickly in the beginning, but just to show you the approaches in cardiac surgery. As we all know, it has to be median sternotomy, and that's the conventional, and that's the standard, and the safest and the state of art. However, we have evolved during the past 4 decades and moved between median to right and left thoracotomy. Why have we moved? Because we believe in a smaller incision. We believe in less scar, less bleeding, less infection, less pain. But of course, it has to be proven. The thoracotomy was causing much worse pain in the past, but it used to be huge. Used to be 12, 14 centimeter. Now we gone down to 2 centimeter for the intercostal space. Here you're going to see the contraindication for robotic approach. This is the contraindication that's been published in ISMIC's International Society of Invasive Cardiac Surgery. And they always say, never ever touch it if you are doing robotic. We simply at King Faisal smashed it. In Cleveland Clinic, they reject any obese patient. Morbidity or morbidly obese is not even discussed. So BMI of 30 is rejected for robotics. Our rate of obesity is reaching 60% for patients with BMI of 30. Patient with BMI of 40 is reaching 28%. So a patient with redo, here it's a contraindication. Redo rate, we reach 32%. Here it says contraindication, pulmonary hypertension. We are 1/3 of our patients are pulmonary hypertension. We have done a copious amount of patients with pictus carinatum, pictus expiatum. So it's exactly what Rakan said. Really, I completely agree with your presentation, and I loved it. It's seriously, when you first you practice and you can raise 100 patent and get nothing. You can work all your life for 1 patent and you reach. I think you start slow for the triathlon and to reach the point. Exactly. We started slow, but sustainability was there, consistency was there, and we kept testing ourselves and the results and we kept on weekly base sit together and debrief our cases until we got really our success rate. Why? Team approach. This procedure is successful because cardiology with cardiac surgery, with anesthesia, perfusion, and nursing, all together we were training in the labs, all together we were knowing our role, doing the dry runs and drills in the OR after working hours in the weekends to reach that. Also, I again love your sketches, Rakan. They're amazing, and it's exactly what we have to do. We need to do sketches in order to prior to surgery to know what we're doing, such as this one. I had this patient and I had to do surgery for him. He's got this sort of aorta, Rakan, and tell me what you think. And in CT scan and with a barrel chest. And I had to take this patient to OR and I had to perform a minimally invasive approach with thoracotomy. So I really had to draw down and try to find the safest approach, not only surgical, but perfusion-wise, covering the cerebral vasculature and oxygenation, the lower limb as well, getting into ways, talking to my assistant. So discussion and sketching and drawing, and even in mentality and your mind, I'm sure every one of us in this room get into this stage. These are the patients we're doing, or some of the patients we're doing. You look at these, not even Pictus Excarius, and this patient is patient number 13 in my program. He is a father of a chairman in our hospital. He has a diaphragmatic hernia. He has lung cancer. He's got liver cancer, both in remission. He's got aberrant vasculature. So basically, lower limb, he doesn't have the proper femoral artery and vein. All of us depend in robotics on the femoral muscles, on the femoral vessels. So, and he refused at the age of 74, refused to have surgery conventionally. So I had to cannulate him centrally through a thoracotomy, but it wasn't 2 centimeter. I had to do it around 6 centimeter in order. Yeah, and he's dwarf as well. So, and I had to do it, and as you see here, through the thoracotomy, through the small thoracotomy here, you see the cannula here between the intercostal space. So it's really sometimes challenging. These are how we progressed. We started a laparoscopic approach, doing all these procedures, not only P2 resection, but we do up to 12 neocords, meaning all the scallops of all the anterior and posterior mitral valve. We address it. Any sort of complex mitral valve and tricuspid valve, we will approach it. We'll approach a minimally invasive approach and robotically, and we repair it. Unless it's rheumatic heart disease, then we replace, because we have done loads of these that fails. This is a patient. This patient is patient number 6 in my robotic program, cardiac tumor. She came to me and she said, there's no way I'm going to do a sternotomy. And this is 7 by 6 centimeter tumor. It's cystic, so it's fluid inside. And so I had to do the surgery through 3 ports, as you see here, and 3 only ports. And the last port, this one, I had to increase from 8 millimeter to 1.6 millimeter and squeeze this tumor out of it in the gallbladder bag. So I had to push my gallbladder bag and collect this and pull it out. She was discharged home 12 hours after surgery. So these are how it looks in the robotics, but we can approach it for repair, complex repair with multiple neocords, replacement mechanical, and in the end, we take the contour of the breast, and it would not cross 4 centimeter, and it would be always hidden, in addition to the substantial result and outcome. Even with severe MAC, as you see here, MAC is mitral annular calcification. These patients are usually elderly, before above 70 years of age, with connective tissue disease, with dialysis and renal failure, and a history of stroke due to, as you see here, in mitral valve is not really a mitral valve. It's chunk of calcium that I had to chase every single debris in it in order to perform correctly the surgery. And in addition to that, it was a redo surgery, as you see here. So, and look at this, for her, 4 centimeter incision in that. So we can approach any sort of surgery through robotic procedure with proper planning in the team. This is a procedure for mitral repair, and as a matter of fact, as Maze, I'm gonna go quickly just to show you. So you can see this. This is a P2 prolapse that has a huge height of almost 3 centimeter. I rarely, less than 1%, do resection for the P2, almost neocords, but in this case, to avoid SAM, systolic anterior motion, I like to make sure the height of the posterior leaflet does not exceed 2 centimeter. So in here, I do triangular resection, not quadrangular resection, triangular resection, and then I, in addition to that, add neocords. I'm going to continue moving quickly through the surgery, because We have multiple videos to show. So I think here I did even an annulus plication and sliding plasty. And then we closed also the left atrial appendage. We put our cords. This is, I'm showing you our procedure, which is the first worldwide multi-valve robotic approach. So we do triple valve procedures, not only aortic. We are number 2 in the world who does suture full robotic aortic valve replacement. The first center was in West Virginia, where Dr. Mohammed Rashidan, and this is the first time I meet him there. I learned from Vinny Badwar a lot, and I went there to observe him for doing these cases last year, and came back and did 16 of them robotically, as you see. Then came back again and was the third case to do multi-valve approach in addition to MAZE and ASD. In these patients, not only that, this is the aortic valve, and then we went into the mitral valve here, and as you see with neocords, I had to repair the mitral valve, post-aortic valve replacement robotically. So these are the programs in King Faisal. We started the first year, 2017. Our minimally invasive approach for a year, and we did 78 cases. Then 2018 we started robotic. We did 105 cases, and ever since, of course, we dropped down to 68 the COVID year, and then 78, and then jumped again into above 100. Now we're doing around 120 robotics, 0 conversion to sternotomy, less than 2% mortality, to be accurate, 1.7, and readmission is less than 1%. Reduction length of stay, which is I'm gonna show you in here. This is our program for AVR. I just want to show you here our BMI. This is the new program we started less than a year ago. Only 3 centers in the world who are performing this. We went and we proctored Yale and Cleveland Clinic and other couple of hospital for that, but yet our selection criteria, BMI of 35. And this tells you the infrastructure of the team working there. And what's the mean hospital length of stay is 6.1. And why 6.1? Because they're all on warfarin because of mechanical valve. For these patients, because they're young, as you said, as you've seen, the mean age is 34.5. So we studied furthermore to convince the administration. We studied the cost benefits of robots to have my own robot, and now I'm even requesting for the second robot in the cardiac center. We have propensity matched out of all our cohorts, around 40 patients who are mitral valve between sternotomy and robotically approach assisted, and 25 robotic cabbage versus sternotomy cabbage. So we looked in that number, which is 40 mitrals. The total cost of the sternotomy cases were 5.8 million Saudi riyal for these patients after being propensity matched, and these are coded. So all the costs of these patients were taken by our billing and coding, not us, the chief financial officer. And so sternotomy, mitral valve replacements, total of them cost about 5.8 million, versus robotically, they were almost 3 million. So there was 1.8 million or 2 million drop in the cost. In the cabbages, it was much less, but it was 200,000 drop in that small number. So the more you increase, the more you reach the target you're looking for cost effect. These are the evolution of the annual procedures. As I mentioned, these are the comparisons. And look at the average length stay. Why did we save the money? So it's the length of stay, and the sternotomy patient stayed 10.4 days. The robotic patient stayed 6.8 days. When we can also, this is with the cabbages, the one with the valve, because as we mentioned, they're needing warfarin. So we wait a little bit until we build the INR prior to sending them home. However, in cabbage is less than 5 days in robotic. However, it's 8.5 days in sternotomy cases. And remember, our cases that comes to King Faisal are usually medium risk to high risk. So hence why the high days of stays in post-cabbage. So, and this is the Euroscore comparison for both. Can you just give me 1 minute, please, to close? Thank you. So these are the Euroscores, almost the same. The average BMI is the same. However, mechanical ventilation, because we applied ERA's program, Enhanced Recovery After Surgery, to fast track these patients. So robotic cases, ventilations much lower. Usually they get extubated on table or the first couple of hours in ICU versus beyond 10 or 12 hours for the sternotomy cases. Again, for the valve, the same thing. BMI, no differences. And as we've mentioned, sorry, I was going up. So just to summarize last thing, there is still further drop of length of stay when you apply the enhanced recovery, meeting ultra fast track extubation on table. And that you can achieve honestly when you do minimal invasive approach or robotic approach. I want to just conclude right here and say basically why not. This is a patient, this is how sternotomy looking like versus this is the small thoracotomy for robotics. Thank you very much.
Thank you very much, Dr. Feras Khalil. Yes, please. Very, very impressive, fine work, and really congratulations for all the work that's being done at King Faisal Specialist. And I'm sure this will be very interesting for everybody. Next, we will join a continuation of robotic-assisted cardiac surgery. We'll join from Jeddah King Faisal Specialist with Dr. Uthman Aluthman. He will be joining us virtually for another session on robotic surgery. Dr. Uthman, are you with us?
Yes, Assalamu alaikum. I'm trying to share my presentation. Allow me.
Yeah, go ahead, please. Yeah. Can you share?
You see,
No, we don't see it
you
yet.
see it.
Okay, now, yes.
Okay. First of all, Assalamu alaikum. I would like to thank the organizing committee and scientific committee for allowing us to present our work. And congratulations on this excellent, superb meeting. I would join you there, but for unforeseen reason, I could not be in person. I will present our experience with the robotic. I don't have any disclosure. It is like in a box, alive in a box for this patient who is 69 years old, who's diabetic, hypertensive, ex-smoker. presented with the non-STEMI, and actually he was diagnosed with the malignant prostate cancer and had a coronary angiogram before his surgery. Has been discussed in our meeting, and as you can see, the typical patient who comes with the cerebral vessel disease, but due to his prostate cancer, has been discussed in our meeting, either to go for surgery, and which will postpone his surgery for oncology for at least 4 to 6 weeks, or do PCI, which will prolong to 6 months if you go for anticoagulation. Therefore, those patients, we usually see them in our daily practice. After hard team discussion, the decision was to go for robotic lima to LAD plus PCI after he go for his surgery to decrease the perioperative risk. Our routine for robotic surgery is to do a double lumen intubation, which has been done which is taken care of by anesthesia. The position of the patient, as you could see here, is the left chest up and one leg out, as most of the patients, we need them for the robotic positioning. 3 mark size. Usually, there is 2 kinds of robotic surgery, which is the XI and the platform before the SI. The XI, sometimes even if you have those dots or those arms in the same place, the same alignment, that could be that could work. But we do this one according to each patient after doing the CT scan. We do a routine CT scan for all of our patients to plan and perform this. Here you can see we put the stroke car in the same place that we do. Below the nipple in the forearm space, we put it slowly, and we inflate it with the pressure around 10 to 12. And then after that, after we visualize everything, we dock the room. We use arms. There is the luxury to use 4th arm if you need to, but we don't use it in the cabbages. We put the camera, and then we insert each trocar under visualization. And the positioning for each trocar has been detected operative with the marking and with the CT scan, and knowing which is the best for each one to harvest. Could go for the next one. So this is in general how it looks like in the OR. The robot is docked, all the arms, the first arm, the second arm is the camera, and the 4th arm, which is the other instruments. And here you see the surgeon console in the different part of the room. Here you see the robot in motion, and this is the coordination, if you see there in the camera, harvesting the leaf. And some people, they will ask, I use this to harvest the lima, and we could do it minimally invasively. But it makes a huge difference of harvesting the lima instead of doing it robotically or minimally invasively, because of the pain. The incision is smaller, and of the mammary. Here, what you can see here under with the camera, you see the introduction of the ports, each one in the top, one in the bottom. Here you could see the phrenic nerve clearly. Here you see the bottom one, the arm for the robot. And then the thing to do actually is to have both together in the middle and the center. And then you start to remove from the heart, that first robotic cabbages, as most of my colleagues know, we remove around the heart. And then we start to harvest the mammary routine. Do the 2 lines, we usually sit as a pedicle, and then we open the pericardium exactly in the on the top of the LAD, which was precisely pre-operatively. And you could see here in the right corner here is the knee, which is the place that we will make our incision at the top of the LAD. Here you could see it is around 5 centimeters place, which is the diagonal. Here is the position of the patient. We use the stabilizer, the Novo stabilizer to stabilize the heart. And here is the incision, how it looks like. In the middle of the screen here in the dot, you can see the LAD fixed in the middle. And here you see the lima after harvesting it. And you have to trust me that there was a good flow. Post-operatively, we do the lead check for all patients. And if there is any complete revasc, for this patient that particularly, he had his lima to LAD, had the prostate removed, and he came back to complete his other coronaries, which has been completed here successfully by our dear colleague cardiologist, interventional cardiologist. Great job from them. So what is our experience? We publish our data for the hybrid approach, and with the help of colleague in cardiology, we developed a protocol for those patients. Patient with a stable ischemic heart disease go directly to the heart meeting, and then we decide the feasibility for robotic versus not, and then we do robotic lima to LAD, and before discharge we do the complete revasc plus lima check if there is anything to be revasked. If it is an acute coronary syndrome, we have either STEMI or non-STEMI. If it's a STEMI, then we do the culprit PCI, heart team meeting. If the patient deemed to be done before he goes home, then we do robotic on top of the Plavix after a couple of days of stabilization as in-house. And then, you know, the risk of bleeding is a bit higher than the usual cases that we do. For the patient with the non-STEMI with the stable situation, we do robotic lima to LAD, and then the same day, they go from the OR to the cath lab or next day in the morning. Our results is quite promising. Out of the cohort that we did, we selectively chosen them in the beginning of the cohort. But it is mixed between the high risk and the low risk. As you can see here, the low AF, around 9% of our cohort was with the low AF. Majority of the intervention was to the RCA. The average operative time was 164 minutes. Conversion to conversion to the regular conventional was to 1 because of intramural LAD that was not picked preoperatively. That's why we just put the CT scan for all the patients. The ICU stay is less than 24 hours. The mean hospital stay was 5 days, and exploration for bleeding, there was 2 patients. So in conclusion from that study, there is a decrease in the decrease in the length of stay, short hospital stay, quick recovery, and little no blood transfusion requirement. The 3 years follow-up was excellent for all patients, was 100%. 98 patients was free from angina. 2 patients actually came back and revealed a patent lima to LAD, and the PCI was done to the diagonal, and it is in progress for publication. Quality of life also, as my colleague Dr. Feras said, that there is an excellent improve for quality of life in all major results. As you can see, this patient is in cinema in post-op day 5. In conclusion, establishment of robotic hybrid program is feasible with a great potential. The robotic hybrid merge the benefits of the LITA to LAD and less invasive revasc strategy with the PCI to the other coronary lesion. Lower rate of major adverse cardiac and cerebral events at 3 years follow-up. The quality of life is great for all of this patient. Thank you.
Thank you very much, Dr. Uthman. Another impressive results. And I would ask you if you don't mind staying with us for in case
sure.
there are questions. And I probably missed, what was the total number of cases done?
This is the earlier one, is 78. The one that we did on the study is 78, but now we are reaching around 160.
Great, thank you very much. We'll take the next speaker, and Dr. Mohammed Rashidan, and he will be presenting to us his experience for May 6 at King Fahad Medical Center.
Okay, thank you, Dr. Khalid, and thank Dr. Adil for inviting us to talk about Maze procedure. So as Dr. Khalil Feras said, I was trained with the godfather of Maze operation, which is Vinay Badwar, and that's why you see there is a lot of influence in this talk. So atrial fibrillation, it's most common arrhythmia that affect adults, and it has 5-fold increase in risk of stroke, and it's reasonable like for 30% of overall stroke. Male patient between 55 and 75 have a mortality rate of 61% compared with 30% at the same age group without atrial fibrillation. And it's been clearly demonstrated in the STS database, despite the fact that the atrial fibrillation have a worsened survival than malignancy, only like 48.3% with half history of atrial fibrillation undergo an atrial fibrillation surgery in concomitant to cardiac surgery. And this was clearly demonstrated by the data came from European Union that atrial fibrillation, it's actually responsible for 3.5 million people worldwide, affecting and 8.8 million in European Union. It affects 1 in 4 and 55, and it's the incidence of atrial fibrillation, it's increased with age. So when we talk about MAZE, we really need to understand what kind of type of atrial fibrillation we're dealing with. And according to the Heart Rhythm Association guidelines, which was published in 2017, atrial fibrillation divided into 4 major types: paroxysmal atrial fibrillation, which is terminated spontaneously less than 7 days; persistence, which is lasts more than 7 days but less than 1 year; long-standing, which is more than 1 year; and permanent atrial fibrillation. This is when the physician and the patient come to the agreement that this is atrial fibrillation that require no further management. So usually medical management for atrial fibrillation, it's anticoagulation with rhythmic or rate control. It's very high failure rate, and most of the management ultimately directed toward into rate control rather than a rhythm control. So if you look at the guidelines or current guidelines that's available, it's mainly AATS guidelines and STS guidelines. AATS guideline focus on efficacy of the safety of surgical ablation, prevention of stroke, and short and long term of surgical ablation, and improvement of patient quality of life and shortening and long term survival rate. However, the STS database, it's talk about of the indication and the level of recommendation. So AATS guidelines, it's a meta-analysis, did not detect the decrease of the transient attack or stroke, but it showed improved quality of life, and it showed no improvement in 30 days survival. However, it's improved the long-term survival. We're just going to skim it quickly. As you can see here, it's if you do ablation, you have less perioperative pneumonia, no increase in ICU length of stay, and no increase with hospital length of stay if you go for surgical ablation, and no increase in hospital readmission, and no increase of post-operative bleeding, no increase of post-operative renal failure, and no increase with the perioperative stroke or TIA. And there was no difference in stroke prevention with meta-analysis. However, non-randomized data showed there is a lower rate of stroke if you do a surgical ablation. If you look at the STS database, STS database focus mainly on what are the level of recommendation and in terms of ablation. And it's mainly divided into 3, actually. Either the patient coming for mitral valve, which is you already going to open the left atrium, so that the decision is easier. But if the patient comes with other pathologies such as aortic valve or CABG, when are we going to do for him a full biatrial maze and the standalone maze? So I'm not going to go through all these guidelines, but the bottom line is if you have any patient comes to your room with atrial fibrillation, with any kind of surgery, this patient should go for a surgical ablation. So if we look at the data, this data came from Scott Rankin, who's and with Vinay Badwar, and they conclude that there is a lower risk adjusted operative mortality if you compare a patient who has atrial fibrillation with who are overgone or don't overgone surgical ablation. And as you can see here, demonstrate clearly there is a lower operative mortality. So doing maze should not make your surgical complicated, and it should not increase your mortality. And another data came from NIV-8 and also in condition with also West Virginia University was part of this study. When they look into the long-term outcome following a concomitant mitral valve surgery with Cox-Maze surgery, and as you can see that at almost 84 months, the freedom from atrial fibrillation was 66% if you use antiarrhythmic drugs, and 55 you don't use antiarrhythmic drugs. And again, and this the good thing about this study, they look into what are the reasons that the patient will have a recurrent atrial fibrillation after surgery. And the number reason one was the duration of atrial fibrillation, means if the patient referred for correction and the atrial fibrillation was prolonged or long-standing or permanent, the risk of of recurrent of atrial fibrillation is high. Also, the surgeon experience, if the surgeon doesn't have experience how to do it, the operation, and the other way, the energy source. Using a cryothermia ablation, which we will demonstrate next, has the best outcome compared with use RF energy source. So if you look also not only into mitral valve, but also in coronary artery disease, this also came from the West Virginia group. You see that the 1-year mortality and cost associated if the patient comes with coronary artery disease who had atrial fibrillation, if you do a surgical ablation for them, they will have a better survival rate after 1 year. This paper came actually from, driven by Mark Guilleneau from Cleveland Clinic. And this paper make a lot of confusion in the surgical community because he looked into a mitral valve surgery, if you do it alone and if you do it with ablation, and you see that the freedom from atrial fibrillation was doubled. But however, when you compare a biatrial maze procedure versus only a BVI, he did not show any difference. But if you look at multiple data actually came after that, and also this is from the Cardiothoracic Surgical Trial Network, which also driven, Mark Guilleneau was also part of this paper. You can see here, if you do a mitral valve surgery and you do ablation, if you do a biatrial maze, it's associated with a very lower risk of atrial fibrillation recurrence. And even though a meta-analysis came from China, showed the same result, that mean no difference in if you do a biatrial maze or left atrial in maintaining sinus rhythm at discharge at 6 months, but they did not look into the long-term outcome. And there was no difference if you do a biatrial or left atrial only in terms of stroke. However, if you do a biatrial lesion set, you will have a higher risk of pacemaker requirement. And again, this paper came from Russia actually, which comparing if you do a left atrial set with biatrial set in terms of recurrence of atrial fibrillation. And you can see here, if you do a biatrial set, you will have a better chance staying in sinus rhythm, but the cost is you will end up with a higher rate of pacemaker needed and a higher rate of sinus node dysfunction. And Ralph Damiano, he is in St. Louis. He's another big name in arrhythmia surgery. Both him and Vinay was actually trained with Cox-Maze. And as you can see here, this data show us the long-term outcome at 5 years. And you can see here if you do paroxysmal atrial fibrillation, non-paroxysmal atrial fibrillation associated with actually almost the same rate of atrial fibrillation recurrence at 5 years. And even though if you do it, if you compare lone atrial fibrillation or concomitant atrial fibrillation, there was no difference in terms of freedom of atrial fibrillation. But again, the finding was that if the patient comes with longest or prolonged standing atrial fibrillation, the rate of AFib recurrence was higher. And this is another paper which came from the also Ralph Damiano group, that showed if you do a COX-MACE-4 for patients who have atrial fibrillation, they have a better overall survival of patients who have atrial fibrillation who did not have an ablation. And if you compare this group of patients with the survival of general population, they have actually the same survival. And this is again in the paper came from Vinay Badwar into looking into what are the trends in the states and what are the most common procedure associated with MACE. And you can see the mitral valve was the most common associated procedure with MACE. And again, it showed no increase in mortality. So this paper I published actually when I was in West Virginia about how should we do this procedure, because the problem with atrial fibrillation surgery, there is too many modification and everybody is coming with a new lesion set. But if you look at how did the COX-MACE prescribe this and how does it evolve, I don't have time to go through this, but this is the lesion set. So practically we have left and right, and we will, when we go through the presentation, we'll explain this in details. So this is for a video case that I have done recently. It's a patient who have severe mitral regurgitation with, as you can see here, severe dilated left atrium, dilated left ventricle with an ejection fraction about 40%, who presented to our hospital with history of compensated heart failure. So we do this procedure minimally invasive through a right groin cannulation, right thoracotomy incision. We go on pump and we open the pericardium through the mini thoracotomy, as you can see here. After that, we insert the scope and we prepare the case. Here, we actually cross-clamped and we arrested the heart using a custodial cardioplagia. Here you can see how does the heart nicely arrested and totally decompressed. After that, I proceed with opening the left atrium. This is all done through the mini thoracotomy. Then we put the left atrial retractor to be able to expose the left atrium and to identify the lesion set for the mitral valve. We start this procedure with doing the coronary sinus lesion. As you can see here, the probe it's going from epicardial surface of the heart into the coronary sinus, toward the mitral valve annulus, into the B3 area, and then we start to freeze. I use all this patient. I use cryo, and after I freeze here, as you can see in the next, we will do a marking just to mark the corresponding area into the mitral valve annulus, because we have to finish this line later on with the same line of ablation to the mitral valve annulus to prevent the left atrial flutter. After that, I proceed with the isolation for the pulmonary vein. As you can see here, the probe going from the left atrium to the pulmonary to the left atrial appendage, and then we freeze. And I usually freeze between 2 to 3 minutes. It depends on the left atrial size and the thickness of the wall. And then we do what you call the J lesion to complete the isolation of the pulmonary vein, the posterior wall. As you can see, this is going from the superior border of the left atrium all the way down to the previous line, the one you see here. Then we finish the left atrial by doing the mitral annulus lesion here, as you can see here, by using the probe into the mitral valve annulus near to the P3 area. As you can see here, this is freezing, and I like to see this, because I know that the lesion is transmural. Then we open the right atrium to complete the biatrial set. If we do this robotically, it will be easy because we can put the retractor, but because we're doing this minimally invasive, I do usually 2 stitches into the right atrial wall. The first lesion, it's going from the upper border of the right atriotomy to the tricuspid valve annulus between the anterior and posterior leaflet, as you can see here. And while we're doing this, we're giving the patient cardioplagia because at this point, the right coronary artery is in very close proximity, and we have to prevent any lesion to the right coronary artery. After finish this lesion, we proceed with an SVC lesion, and as you can see here, it goes from the lower edge of the arteriotomy to the wall of the SVC, as you can see here, and then we freeze. Again, this depends. I do usually between 1 to 2 minutes. It depends on the transmurality, and it depends on the thickness of the right atrial wall. And it's very important to follow the same lines just to prevent the recurrence of the atrial fibrillation. After finishing this set or of this lesion on the right, you will see next is when we do this is the right atrial body, which we go from the upper border to the right atrial appendage. And finally, we finish this by doing the inferior vena cava lesion, which we go from the left, from the lower edge of the right atriotomy to the, as you can see next in this video, to the IVC. As you can see here, it's the white dot here, it's the freezing. Sorry, just go back, I'm sorry. So then we close the left atrial appendage. I usually do 2 layers of closure, which is done all through, again, minimally invasive. Let me fasten this because it might be this is how does it look when you close. It's 2 layers closure of the left atrial appendage. After that, we repair the mitral valve, minimally invasive. Sorry. And we do the ring, and we put the ring to the patient. Then we fix it with the cornet. Then we test the valve, as you can see here with the water test, and the valve looks very competent. After that, we close the left atrial appendage, sorry, the left atrium and the right atrium. And this is how does, sorry, this is the pre-operative echo. Oh, because it starts from the beginning, I'm sorry. Let's look at the post-op echo. This is how the valve looks competent with no mitral regurgitation. So how are we doing in King Fahd Medical City? So far, we have 56 patients, 54 male and 46 female. Our mean age is 51 years old. This is the preoperative characteristics. I just want you to bear with me here. You can see here that our PMI is like 29, but I have done a patient up to 35 PMI. Most of these patients, they have New York Association class actually 2 to 3, but mainly class 3. And they are like with regular kind of patient with all kind of comorbidities with the previous stroke. So the most common procedure associated with this, it's the mitral valve replacement, because most of these cases actually rheumatic with severe MS. But I still have a patient who have redos. I do them with maze and minimally invasive or mitral valve repair. The other concomitant procedure associated mainly, it's the aortic valve replacement, CABG, ascending aortic replacement, and tricuspid valve repair. So our preoperative echo, because always the argument with people, left atrial size. I have to tell you, most of my patients, they have severely dilated left atrium. I don't look at the left atrium size. I'm sorry, but maybe it's 10, yes, but 7, 8, I still ablate them because I believe using cryo and doing this systematic, you will be able to get a very good outcome. This is our post-operative data, and this is the real data. We have 2 mortalities, and we have 2 patients needed the pacemaker. It's only 3.6% pacemaker needed. And we have average ICU stay about 5 days and average hospital stay of 2 weeks, because I have to tell you, these patients sometimes they take them time to, because they are an amiodarone infusion, they require atrial pacing, and also when we do MACE, sometimes they lose their atrial nitric peptide, so they have a lot of high incidence of having fluid retention, though we have to decrease them like crazy. Most of patients were in anticoagulation, but because we replaced most of the valves, and number 1 reason was a mechanical valve replacement. So why we doing this for the patient? And this is clearly demonstrated here. You can see here after follow-up, most of the cases, they come as class 3, as I said. And as you can see with time, class 3 is dropping, and most of the patient class is staying in class 1 and class 2 New York Heart Association. What our freedom from atrial fibrillation, we have up to, this data is up to 12 months, but I have patients up to 3 years. But because, you know, this program started 3 years ago, up to now, we have a 94% freedom from atrial fibrillation. And if you look at freedom from stroke, 98% of the patient, they are freed from stroke. We are also looking into freedom from antiarrhythmic medication, and also the quality of life, which is things we are also looking into, and this will be presented next. So in conclusion, Cox-Maze 4 is a safe procedure with low morbidities and mortalities. It's associated with improvement in heart failure symptoms and associated with low rate of free current of atrial fibrillation. It's associated with decreased risk of stroke. It should be done systematic, and it required special training. And Cox-Maze 4 can be done through any approach, can be done through sternotomy, minimally invasive, and robotics. Thank you so much.
Thank you very much, Dr. Muhammad, for excellent results. Very impressive, صراحة. Now I would ask you to join us here, and if we could have questions, please. We can also have questions between panels. Right? Yeah.
Oh, all right. I really enjoyed also your presentation and Dr. Uthman Aluthman's presentation. So I've got a question for you. I'm a big support of Maze, honestly, and I agree with you. We should not limit ourselves to 7 and 8 or to 6 only centimeter of length. I think it is clear that when it is 6 centimeter diameter of the left atrium and below, you're going to have higher success rate. Nevertheless, if you still continue doing it to the 7 and 8 centimeter, you're going to have some success. It might not reach 96%, but it's going to reach at least 50%. And if it reaches 50%, you're going to have 50% chance of avoiding and refraining the patients from having stroke. So that's number one. However, my question to you is, as we all know, it is done as a standalone. Why have we surgeons failed in delivering this message to the cardiology society, to the general practitioner, to the family medicine, to not only that, to the neurology? Because there are 70 years old ladies and gentlemen who are on having neurological problems with some sort of syndromes that they cannot be on dual antiplatelet therapy or NOAC. Why can't we take these? Especially that, as you mentioned, it can be done minimally invasive, it can be done robotically, it can be done safely with sternotomy. Why can't we sell that? Why still the electrophysiologists are able to ablate with 1,100 new techniques that comes every time, and the failure is still high? And I respect our colleagues, the electrophysiologists, big time, because they do fantastic job with all these beautiful radiofrequency ablation. Nevertheless, we do a fantastic job as well. 98% of freedom. You are able to ligate the left atrial appendage, which is the source of stroke. Then why aren't we able to deliver the message?
Thank you so much. I think to answer this question, it has actually two sides. Side number one is the surgeon themselves. I think the people still, as a surgeon, they think that doing a Maze procedure is complicated. It will increase their OR time. It will increase their risk of bleeding. You're a surgeon and you understand. So we clearly demonstrate here that it will not increase your operative mortality. It will not increase your risk of, it's actually the same as like doing any open heart surgery. On the other side, it's the cardiologists themselves and the community, because still some practitioners and cardiologists believe that atrial fibrillation is a benign disease, and it's clearly demonstrated that the outcome and the survival of the patient with atrial fibrillation, it's actually drop for sure. This patient, they are on antiarrhythmic, they are on anticoagulation, they will have all these kind of complications, stroke, bleeding. So I believe I actually presented the standalone data on New York with Vinay in 2019 in New York. We demonstrated freedom from atrial fibrillation standalone means up to 98%. With a similar, with a 70% of the patient extubated in the table in the operating room. So it is a safer procedure. I think it needs, we need to make it more popular in our community and make the surgeon actually more adapting the technique. And we need to treat our, to teach our colleagues in electrophysiology and cardiology about that. What I have done to get a lot of cases, I did what you called atrial fibrillation group, which is electrophysiologist and the cardiologist and the surgeon. And then we pull the cases once a weekly, and then we discuss the cases who should go for catheter right away, who should go for surgery, who should go for medical therapy, you know. I think this will increase the awareness and it will increase the referral of the cases.
Thank you very much. حقيقة يعني I'm really excited and proud to have you all here in this meeting, and congratulations on all the advances that you had in your centers and your personal development as surgeons. Dr. Nader, Dr. Uthman Aluthman, Dr. Muhammad, Dr. Feras. Really, you're now not newcomers in the field. You're at the peak of your careers, and you are advancing in a way that is really impressive, really impressive. Now, my question is, now we have robotic surgery, we have minimally invasive, we have the Maze Cox or the ablation surgery. And Dr. Khalid Iskander also started the Ozaki, and Dr. Muhammad also did a few cases of Ozaki aortic repair. Our noise as a surgical community and our spread of the knowledge, as Khalid was just telling me, that we really need to reach our fellow cardiologists, tell them that these are things that we could do. This is the value we add to the patient's community. Now, I want to probably we'll start with Rakan, and we'll go across the panel, and then also from the audience, from our senior cardiologists. Why are we not as we don't meet as much as the cardiologists? We don't show our results like the live streaming and live transmission, and the more discussions and the more interaction with surgeons. Why do you think surgeons shy away from that? Is it because of the workload? Is it because of the stress, or are there any other? And how can we make this better? How can we make this better? That's I think the fundamental question.
Thank you, Dr. Adil. Again, very thoughtful question. To me, in my mind, and I've done minimal invasive early in my career, and then I went full-blown open. And the realization I came to after a few years in practice, at least where I did my practice, was that if you want to do more, if you want to have the best results, then you have to have two fundamental criteria. Number one, you have to have ease of adaptability. My issue with minimal invasive and robotic is it takes a steep learning curve for both the surgeon and the team, and the cost is beyond what most regular institutions can bear. Number two, reproducibility. Again, if you look at all of the procedures that we perform in cardiac surgery, and the reason why we're still in business, me and Dr. Muhammad have spoken about this earlier, is that CABG, for the last 50 years, the data has been conclusive. No procedure in history in medicine has been thoroughly studied and scrutinized as CABG, and yet the results are persistent. And the reason is it's easily reproducible, and the results are consistent. So to answer your question is, if you want to reach out to the cardiologist, if you want to reach out to the community even, you need to show that these procedures can be reproducible and done easily in multiple centers. I always said it. I trained with Tyrone David at the time when he was one of the few people in the world who did the valve sparing. And I came to the realization it was a useless operation. Useless. What use of a procedure if only one or two people in the world can perform it, and if you can do it? And I remember this amazing, I once was scrubbed with Tyrone David, and he said he went to a he was awarded a national prize in Russia. And he went there, he was invited, he was one of the awardees, and he sat on a table who had all Nobel laureates. These are people who really impacted humanity in ways you can never imagine. And he said, here I was sitting amongst them. Now, as you all know, Tyrone is like the god of cardiac surgery. At the time, he was at his peak. And he said, I felt like nothing. Because again, it comes down to the impact. How can we make minimal invasive, robotic, futuristic approaches more widely available? Is again, as I said in my innovation lecture, is you need to do more. There must be a way to make it better. When I met my mentor in innovation, he's a pediatric surgeon, Dr. Ayman Al-Jazairi. And I said, I have these ideas of innovation. He said, forget about it. What do you do every day in the operating room? I said, we open the chest and cannulate. He said, there must be a way to make it easier. In fact, that was one of the patents that I've made, is how to do the sternotomy, again, from easier, more reproducible. So again, that's my own take.
I think one of the things that Dr. Mohammed Rashedan mentioned is a lot of cardiac surgeons, who are not exposed to maze procedures, they think that maze is complicated. And we need to start among ourselves as surgeons for those who believe that it's more complicated, maybe we should have workshops or have surgeons who do it frequently to come and visit those centers and get and show the other surgeons and train them and show them that it's actually not that difficult. It's just like any other open heart surgery that we do, and that we need to start with ourselves first, and then I'm sure surgeons who are doing it in their hospitals, like Dr. Feras and Dr. Mohammed Rashedan, the cardiologists in those hospitals, they know that these guys, they do these procedures, so they refer them these cases along with whatever surgery concomitant that the patient is requiring. The other question I actually have for Dr. Feras, I was impressed that the robotic surgery cost was less than the normal straightforward surgery, because I do understand, appreciate that the length of stay is less, but also the operating time is very expensive, the number of hours and then there are other expenses and disposables and things that are involved in robotic surgery that are more costly than the normal disposables. I would be interested to hear your opinion, because the difference that you showed is really big cost saving and big cost efficiency in this.
But before Feras, if you don't mind, I want to carry on with what you were saying, and we were discussing Khalid, and what Rakan, you said, the reproducibility, and I think that's probably the magic word. When every surgeon can understand the procedure and can perform it. And I think we have an experience together now with the Ozaki and the Ozaki kit. Having a kit and having a way that this is a standardized way, like Carpenter, what he did with the mitral repair. He standardized the mitral repair, how we think about the mitral repair. And now I think it's time to really standardize what we do in minimally invasive and in robotic, and and in maze, and how, like for example, not every center can have a robot, but I think every center should perform minimally invasive cardiac surgery, and every center should perform like mitral repair. It's not acceptable for a P2 prolapse now, which I hear about in the Ministry of Health nowadays, that first of all, they get a full sternotomy for just a P2 prolapse. Second of all, they get a replacement. And that's really a shame. Sometimes when I hear about these cases, I get ashamed that we need to reach to those surgeons, and we need to teach them how to do mitral repair and how to perform it minimally invasively as a second step. I'll leave Feras to comment, and then Mohammed Rashedan. But first, Feras, comment about this and comment about the cost.
Okay, I'll start with the last question. I think it is really crucial in any specialization, any field, to have centralization. So I don't believe that every center has to be the best center for mitral repair. I don't believe that every center has to do robotics or minimally invasive, and I don't believe every center has to do LVAD or transplant. For the reason is that centralization. If I have a patient who's needing aortic root, honestly, it should go to a person who dedicated for training, Rakan, Turk al-Bakr, and other surgeons who has done aortic root. So that's my mentality. The reason why it has been published in the literature, where you're going to have better outcome with high volume. That's for one. However, I completely agree with you, Dr. Tash, in a P2 resection that goes for replacement is a crime. It is done, I've seen it, and it is continuously done. I think the mitral valve and like the aortic valve or whatever, it needs to be understood. Not any surgeon can do that. So centralization is the way. And one comment in regards of centralization, you can do a fellowship and concentrate these fellows to go and learn the aortic root surgery from Dr. Rakan Nazer, the maze ablation and mini mitrals from Dr. Shidan, LVADs, the doctor, or beating heart. That's what I think. Now, going back to the first question, Dr. Skandar, that's a very good question. And Da Vinci Intuitive Surgical said break even is at 54. So patient 54 per year. If you do 54 per year robotic cardiac surgery, that's the break even. So this is when you stop wasting money for disposable. Beyond 54, you're going to start saving and making money, because it is only a third gets 1 unit of blood products, not necessarily RBCs. 1 unit. 1/3 gets 1 unit. So super low. It's more than 3-fold low than the sternotomy. 1 unit of blood products is a $1,000. 1 hour in the ICU is, you know how much it costs, is also around $3,000. So if you drop these down and these patients start going, sending them back to step down unit recovery or CVT rather to bypass the ICU, then you're going to drop a lot of money. But you cannot have a robot and just do 15 or 20. Yeah.
Thank you, Dr. Adil, and thank you for all panelists for their outstanding opinions. But I think I trained in mitral valve surgery and in maze operation. Like I dedicate 1 year of my training just to do a mitral valve repair and maze procedure. And I have to tell you, the problem is the volume in Saudi Arabia is low. If you're gonna train a surgeon to do a mitral valve repair and he will do 2 cases a year, he will not have a very good reputation and very good outcome. And we cannot look at his outcome because he's doing only 2 cases per year. So I believe mitral valve surgery, it should be, I would not say it centralized, but it should be consolidated. You know, like let's say example in southern region, you have Asir, let's example, Al-Baha, whatever. I think the cases should be directed to a surgeon who will have the volume, and then you can build on him. And what we can do, we can help him as a community. We can go with him, help him set up a minimally invasive, help him in purchasing instruments, and doing cases with him in the beginning till he's standing his legs so he can be in his own. This is one thing. The other thing is the problem with, as Dr. Feras said, the problem with the surgical techniques, it really needed special training. How I became interested in maze and how I have this good outcome, because I was doing 4 cases a week in West Virginia. I was watching. In the beginning, they don't let me touch anything because they worried about their outcome. Then I start doing the easy lesions in the right. and then I finish up. I really understood this procedure after 1 year, after doing it full and having the 3D, as you said, the 3D reconstruction, because every atrium, everybody think the atrium is the same. It's not the same. Every time you have to have a different angles. So you really have to understand your lesion set and how you should use the technology. So I think in Saudi now, how I see this, I think robotic surgery should be done maybe in each region. We should have 1 or 2 centers maximum. Mitral valve surgery should be consolidated in the highest volume centers with special surgical training. I think Maze, I really want to spread the knowledge of Maze, and that's why I actually am presenting this data here. I presented it in Saudi Heart, and also I reach out to Vinay because I want to go and present our data in States, because they don't do robotic. Most of their cases are degenerative. So we have different pathology. Our patients are more difficult. We have a different population, and you know what? We have a better outcome. We have a very good outcome compared with what people are doing. So I think what you're doing, Dr. Adil, in terms of National Heart, with your initiatives, helping other surgeons, it's actually amazing, because you will have the overview of where you should direct the resources and how you would build a capability and reputation. Thank you.
I think, yani, we can, thank you very much. We can utilize the virtual hospital to discuss more cases and instruct surgeons. Dr. Shukri. Yes, yeah, channel the referrals, yeah, and consolidate cases like Dr. Shadan was saying.
Allow a cardiologist to comment on some
Cardiologist.
This is really
cardiologist.
quite
we need
a
you. We need
privilege
you to believe in
actually,
us. Yeah, the
actually
first
quite
thing
a-
is we need you
quite
to
a
believe in us.
privilege, to actually hear this discussion. I totally agree with Dr. Feras that we do really need to think of specialization. We cannot really afford to disseminate this to every corner. This is not like common day surgery that's a broken bone that needs to be fixed in every emergency room. These are highly specialized procedures, and there is a big spectrum and difference between good outcome and poor outcome. And we don't have that transparency. Today, everyone tells you, I have done 1 million of this procedure and I've had no mortalities and nothing to support this. And we always hear discussions that we've done this and we have perfect, nothing comes back, without really objective data or unbiased registries to actually prove this. This has an impact on training. And my biggest concern is that as we are heading towards privatization, this is going to have a major impact. If I'm a surgeon, I'm going to be very reluctant to refer to Fawaz or to anyone else. I want to do that case because I'm going to get to earn the income for that. And that really spells disaster for me in the future, that if everyone pretends to be able or capable of doing everything, then we will have poorer outcome. And the only way, in my mind, we can actually prevent this from happening is that we have a system which actually allocates where we're going to put the resources, what size of surgical practice we have, where we need to have the center, where is the population where we need a center in that place, we need a center in that place, in this place. And these can do this procedure and other places can do other procedures. And that way we have equity and we serve the population needs, we serve the patient needs, and not just the ego of an individual physician.
Thank you very much, Dr. Shukri. Dr. Uthman, would you like to add anything from your perspective? I'm not sure if Dr. Uthman is with us. Yeah, please go ahead.
Thank you very much. I really enjoyed the discussion. I can't add more to my colleague. I think the only thing that I would add is to have more meetings to present like this. Thank you, Dr. Flash, for this initiative. Dr. Skander and my colleague. I think we should do it quite often to present this and to spread the knowledge.
Thank you very much, Dr. Uthman. And, I really can't, I'm really amazed by the cases that were presented today, by the presentations, by the level that we have reached as a surgical community in Saudi Arabia. And by the new generation of surgeons that will take this specialty to higher and bigger grounds. Now, Sahha Virtual Hospital, you are all part of Sahha Virtual Hospital. We meet there. We want to consolidate cases. We want to discuss more cases. We will invite more and more surgeons, especially from the periphery hospitals, to discuss their cases with us, both surgeons and cardiologists. And we do want to organize it in a way that we consolidate cases and of certain specialties in certain centers with our support. Dr. Rashedan can help with the repair cases, the minimally invasive, the maze cases. Dr. Nazer, Dr. Turki Bakr with the aortic cases, and Dr. Feras Khalil, Dr. Uthman with the robotic. We have other surgeons that do adult congenital. We have other surgeons that do roots, the transplants, LVADs. We need to discuss more cases, and we really need to provide our patients with the best care. It's not now acceptable for a surgeon that does only 2 repairs a year to go ahead, even if he has and if he gets a case of repair, to convince the patient that he can do it and does it alone. No, we need to collaborate in all these. I don't, I don't blame surgeons for doing emergency cases, that they're there to save patients' lives. But if you have an elective case with a mitral repair, don't do it alone. Ask for help, and we definitely at Sahha Virtual Hospital will help you. The surgeons around the kingdom will come together at this place, Sahha Virtual Hospital. National Heart will help. Saudi Heart Association will help. We need to come together in such meetings, present our cases, look at our work, look at our data, collect our data first of all, and progress. But I'm really happy and delighted from what I saw today, Al-Haqiqa, and looking forward to further pure surgical meetings where we can discuss further and go in depth into more subjects. Thank you. Do you have anything else?
Well, thank you very much. That will conclude the day, and we're looking forward to see you tomorrow for more exciting sessions. Thank you.